Got it. Okay, it's 101, so we'll go ahead and get started as people are joining. Thanks everyone for tuning into this installment of the National Fellow Online Lecture Series presented by the AMSSM. I'm Robbie Bowers, and I work at Emory in Atlanta through the Rehab Medicine Department and Orthopedics, and I will be moderating the session for today. And so let's go through some housekeeping real quick before we get started. So just so everyone knows, the next lecture will be on September 2nd at 12 p.m. Eastern Time. It'll be on the Athletic Cart with Aaron Bagish. Heather Saffel will be moderating that talk. As far as today's talks are concerned, again, I'll be moderating and we'll handle all the questions. We'll have two talks today, each 25 minutes to 30 minutes in length. So first will be sports-related cervical spine injuries with Dr. Ed Laskowski from the Mayo Clinic in Rochester, Minnesota. And secondly, Sideline Emergencies with Dr. Jeremy Whitley, who is also at Emory in Atlanta. We were fellows together several years ago. And a few housekeeping issues. So this is to serve as an adjunct to the fellows' education they get. We're not trying to replace anything more. It's just an adjunct, and want to give fellows direct access to educational experiences with experienced AMSSM members, guest experts, and maybe those who you haven't heard speak before, either at a national conference or elsewhere. And the overall goal of this is to help you to assist in CAQ exam preparation. So just a couple things. Most people will be muted automatically, but just make sure to mute your device's microphone, turn off your video. One thing that we have not had a lot of thus far, this is the 5th lecture, I believe, is that we haven't had a lot of questions. So please feel free, and I encourage you to submit questions through the chat function. Include your name and program if you wish. You don't have to if you don't want to, but questions are greatly needed. And I will ask the questions at the end based on what is submitted. And after the program, please complete the evaluation. It'll be sent at the end of the lecture. I'll also put a link to the evaluation in the chat function. And so a little bit, I'm gonna go back here. Sorry about that. Back here real quick, a little bit about our speakers today. So first, Dr. Ed Laskowski, a professor in the Department of PM&R at Mayo Clinic in Rochester, undergraduate at Duke, MD at Northwestern, his PM&R residency at Mayo Clinic. He's been active in research over the years and is pivotal in the Mayo Sports Medicine Board Review course. His accolades are too many to list individually, and so Dr. Laskowski will get us started with cervical spine injuries, and I will introduce Dr. Jeremy Whitley before his talk, which will get started here in about half an hour. So Dr. Laskowski, feel free to take it away.
All righty, Robbie, thank you very much. Let me know if you have any problems hearing me or anything like that, but pleasure to be here and speak to you all. I hope all are doing well in these crazy times. So we'll talk about pains in the neck, so sports-related cervical spine conditions, and I have nothing to disclose in this lecture.
Dr. Laskowski, we can't see your screen right now.
Ah, okay. It says I'm screen sharing.
Oh, it is. Jeremy, stop sharing your screen for now.
Sure.
Okay, there we go. We got it.
All right.
Got it?
Yep.
Okay, so alrighty. So we're going to just go through the differential diagnoses of cervical spine pain and how we evaluate them, especially as far as the athlete is concerned, how we evaluate the cervical spine injury. I'm sure Jeremy will build on that as well with sideline emergencies, and then return to play criteria for cervical spine conditions. So epidemiology, there's about 10,000 cases of C-spine injury each year in the United States. About 10% of these are athletic event related. Again, major cause of spinal cord injury in the first 3 decades of life. A smaller portion of all sports related injuries, but when they occur, they're very highly publicized. You know, about Sonny Bono, one of the Kennedys. A lot of these occur really during unsupervised sports. They're diving, skiing, sandlot games, and so not the majority during organized sports. This is a nice question because, again, we think of football, but in absolute numbers, recreational diving is actually the leading cause of SCI leading to quadriplegia. So it's usually, again, they're diving in shallow water. Usually alcohol is involved. There's bad technique with diving, but recreational diving is the leading spinal cord injury cause. But you know, again, we hear about the high-profile cases that occur in sports as well. In high school sports, it's a small incidence, about 3 per 100,000, but as you'd expect, the contact sports are the greatest. So football, #1, then wrestling and girls gymnastics. Most of the time, there's muscle injury, nerve injury, about 1/5 of the time. This is a contact injury in large cases. So about, as opposed to ACL, which is non-contact, about 70% here is contact with a player, about 16 to 20% contact with a playing surface. Again, as you'd expect, high-risk sports in the United States, football, gymnastics, wrestling. In Europe, rugby, so there is a country differentiation there. Ice hockey, as you'd expect in Canada. Certainly the snow sports, cycling, and equestrian sports, again, at high risk. In football, this is our high-profile group. There's about 684 deaths in amateur and pro football. That was from the period of 1945 to 94. About 20% of those deaths were related to cervical spine injuries. So certainly a larger problem in those earlier years. You know, again, you can kind of see the distribution of who gets it and where they get it, and as far as how experienced they are. More high schoolers, college, as we get to the professional levels, less so. Deaths, there was 28 TBI and SCI in high school and college football players from 2005 to 2014. 18% TBI had concussions earlier. So again, that second impact syndrome, but these were actually spinal cord injured individuals as well, not just brain injured individuals. There's a nice study in college football from the NCAA database. Stingers, you can see the incidence there, about 2 per 10,000. Cervical strains, about 0.8 per 10,000. Again, as in a lot of things, 9 times more common in games than practice. Highest in Division I athletes, again, a large amount of contact related. Most common positions, linebackers had about 1/5 of them. And most people did return to play within 24 hours. So these were more the cervical spine strains and not severe injuries. Ice hockey in Canada, nice study. Most involved contact with the boards, some illegal checking. But again, how rule changes can make a difference. And we'll talk about this in football, as you all are familiar with spearing. But in hockey, about a 70% decrease in cervical spine injuries following a penalty for checking from behind and for boarding. So huge difference that rule change made in hockey. Anatomy is testable. A lot of things, you know, in this board exam, you know, we could try and make it as clear as possible, but anatomy is not a gray area. So know your anatomy. 7 cervical vertebrae, as you know, 8 pairs of spinal nerves. They always like to ask that the cervical nerves exit above each vertebra. So they may give you an MRI and a little arrow pointing to a nerve root, and you'll know which it is because you'll know in the cervical spine that above is the exit of the nerves. We need cervical lordosis. Lordosis absorbs force. When that lordosis is gone, we'll talk about spearing a little bit later. When you create a rigidity, that's going to be a risk factor for injury. So we want a normal cervical lordosis. The cervical spinous processes are normally bifid. And again, just nice to have a root screen. So when somebody has upper extremity symptoms, C5, and again, there's overlap, but in general, C5, biceps and deltoid, if you manual muscle test, C6, your wrist extensors, C7, triceps, and C8T1 interossi. That's a good root screen for each of those nerve roots. Again, sensory dermatomes, kind of the same. C6 is going to be your radial side, your thumb. Think of C6 shooter, okay, a gun, that's C6, C7, basically the middle finger. C8T1, the ulnar side. Again, these will vary depending on which dermatome and which sensory dermatome map you see. But in general, you're going to have the radial side C6, the middle C7, C8 ulnar side. So if pain is in these distributions, we can get a clue as to what nerve root is involved. There's a broad spectrum of injuries of the C-spine in sports. Fortunately, the large amount are not catastrophic and not very limiting. And there's an inverse relationship to the frequency of injury and severity, meaning the most frequent injuries are the least severe. But again, we want to pay attention because the most severe injuries are very significant. The entities we'll talk about root and plexus lesions of the neuropraxias. We'll talk about cervical strain, the myofascial lesions, intervertebral disc lesions, transient quadriplegia we'll touch on, and then cervical fractures and dislocations. So the neuropraxias, that's the burner or the stinger. And you can think of a neuropraxia as basically a stunning of the nerves. There's a temporary loss of function due to blockage of nerve conduction. And this is the most common cervical spine injury in football. One study had up to almost 70% of college football players during their career experienced a stinger. Very common in linemen and defensive ends. Can be due to the injury to the brachial plexus or the cervical root. And usually this will be, they'll come out, the dead arm sensation, they'll come out, the arm will be lifeless. They'll have maybe burning pain and paresthesias. Transiently, they'll feel like they can't move the arm. To be a stinger or a burner, it should resolve quickly, and usually within 24 hours definitely, but usually within seconds to minutes. Objective findings, you shouldn't have any problem with the C-spine. The C-spine range of motion should be full and pain-free, shouldn't be tender on any of the spinous processes or interspinous ligaments. Maybe there's some transient weakness or sensory exam dysfunction there for a temporary period. You need to do a complete neuro exam to ensure that everything is back to normal. And really, you don't have to have x-rays unless there's persistent pain or bilateral symptoms. Again, anytime bilateral, you think of cord, you think of myelopathy. Unilateral symptoms are usually root symptoms. Mechanism of injury, it can be compression or traction, either one. So it could be ipsilateral or contralateral compression or traction. And so I think this tells it best, actually. So you can actually have a stretch or compression injury, and the same mechanism can produce injuries on opposite sides or direct compression. So I think we think of it a lot as a brachial plexus stretch injury, which it can be, but it can also be a compression injury as well. Important to know what CSF reserve is. A lot of athletes who had burners have limited CSF reserve. And one study showed DJD and neuroforaminal narrowing in about 9 out of 10 of high school athletes. But CSF reserve is if you take the diameter of the cervical spinal cord and that's over the diameter of the cervical spinal canal. The reserve is the amount you have cushioning basically that cervical spinal cord. You know, there isn't a lot of evidence-based research on how much is adequate reserve. We just need reserve. We need that cushioning around there. And with loss of those reserve, that's when we'll talk about transient quadriplegia and all, when that is lost. But we don't have any evidence-based, hang your hat on concrete criteria for how much reserve, but we need to see that T2 signal. We need to see that fluid and that space around the spinal cord. One study in the combine showed less reserve in those who had chronic burners and stingers. So treatment and prevention, really neck strengthening is key. There's been a lot of studies on the equipment that people wear. You may have seen the collars and stuff that end up around the thoracic spine at the end of a game sometimes. So, and the cowboy collar, none of them really have been shown to prevent these. So really well-fitting shoulder pads and good cervical thoracic stability, strengthening is probably the key to preventing these and treating these. Remember, you need normal neuro exam, complete resolution of symptoms before they go back. Strains, there are strains to the ligament or soft tissue structures of the cervical spine. If they're ligament sprains, that's a potential for instability. This can be either a hyperflexion or extension injury. This will have localized pain, usually not radiating into the arms, and they may have painful range of motion. Again, usually myofascial structures. The sprain is when the ligaments are actually involved as well. And again, a lot of these, you can have it from chronic conditions. You think of our road cyclists who are in a forward flex position a lot. So we say that golf ball on the tee, we need cervicothoracic stabilization. When that golf ball falls off the tee, we overload myofascial structures. So the cervical paraspinal muscles and the posterior neck structures, the superior trapezius, that's cumulative microtrauma. And that's going to be from our road cyclists and from those in a forward flex neck position. Poor aerobic conditioning also associated. Our world is in front with Zoom and all the stuff we're doing right now. So we tend to have that golf ball fall off the tee, and then we have that posterior overload from that. Well, if it's just a cervical strain, a myofascial pain, it might be tender in the paraspinous soft tissues. You should not feel any step off or deformity. There should not be a neurologic deficit. If they have, and this is why we cover games, if they have tenderness to palpation over the spinous processes, over an interspinous ligament, if you're covering a game, athlete has an injury, you feel that requires immobilization. So that athlete should be C-spine immobilized in a rigid collar and boarded until you can get imaging. So again, focal tenderness to palpation over the spinous processes, interspinous ligaments, pain with cervical spine range of motion. That's when we want to be cautious. We don't want to take a ligamentous injury that could have gotten better and make it worse by moving somebody who had that condition. The radiographs we get initially, really AP and lateral and odontoid are the key ones initially to see. Just remembering we see all those structures. And really, you don't have to do, you shouldn't do flexion extension initially because they may have a lot of spasm, and you may think they're falsely okay when they're not, because when that spasm loosens, you may see the degree of instability that they have. So if AP lateral odontoid are okay, then you keep them in this hard cervical collar until about a week, 10 days, until those acute symptoms subside. Then you can do flexion extension after that muscle loosens up to rule out any instability. If they continue to have pain to palpation or painful neck range of motion, then you want further imaging, usually an MRI, the exam of choice, because it's going to visualize those ligaments that may be involved as well. Something they always like to ask about, what you don't want to see is what we're seeing here, in the sagittal plane, greater than 3.5 millimeters of angulation or 11 degrees of angulation, greater than 3.5 millimeters of displacement or 11 degrees of angulation, that's cervical spine instability. So that's what we don't want to see, but they always like to ask about these numbers. So again, hard cervical collar, analgesics, again, very gentle stuff initially. Eventually, if it's not involved, if it's a stable spine, you're going to do cervicothoracic stabilization exercise and get them going during that sense. We want to avoid extremes of range of motion during that acute phase. Disc pathology, that's common, can lead to central cord compression and myelopathy if it's central, or it can cause radiculopathy if it's lateral. So there can be a wide range that we can see with disc involvement. And just to know, again, these are very testable questions. They may list categories you can imagine in a STEM or answers from A to E. Upper motor neuron is usually, they're going to have spasticity and increased hyperreflexic status, not hypo. They're going to have a positive Babinski sign. And so that initially that's going to be spastic, hyperreflexive, and positive Babinski. Lower motor neuron, flaccid, decreased or asymmetric reflexes, asymmetrically decreased, atrophy, negative Babinski. So those are, and that may occur pretty quick. You can drop a reflex pretty quick with a radiculopathy, whereas upper motor neuron may take a little bit more time. But very important to know, again, upper motor neuron symptoms usually bilateral. Anytime somebody has bilateral, hey doc, all four, my 4 limbs are numb, that automatically should cue you into cord and myelopathy. If there's a single-sided problem, again, more likely radiculopathy or root problem. But definitely know the upper motor neuron and lower motor neuron differentials there. Radiculopathy, again, disc herniation is the most common cause of this. Sorry, this is a lumbar spine. We're talking about cervical spine, but it's a nice disc here. But, you know, again, there's, as you know, there's a large number of studies that show that disc extrusion itself does not mean a problem, and it does not correlate with pain. There's a lot of data suggesting that there's an inflammatory response around that disc, cytocrines, kallikreins, bradykines, that cause a chemical radiculopathy. That's why we do epidural steroids sometimes to kind of settle that area down. Most common levels, C7, and you can see there it's C6, C8, C5, but C7 most common level. Degenerative changes, again, may lead to that. That can lead to narrowing of the foramen. So can ligamentous hypertrophy, disc degeneration. All those things together cause foraminal stenosis. And when we have the osteophytes and the disc material together, that's a hard disc that can form some fairly significant neuroforaminal stenosis to cause impingement. So you're going to evaluate the same thing we would usually, the mechanism of injury, what they were like before. You want a neurologic review of systems, certainly motor, sensory, and reflex exams, X-rays, and again, if there's a significant deficit, we're going to want an MRI, especially with progressive neurologic deficit. Again, many people are going to have an initial hit. They may have a -1, just a subtle weakness. That's okay. If it's progressive, that's when you want to get more advanced imaging. Oftentimes, they're going to have associated degenerative changes. In one study, up to 75% of freshman football players had early cervical spine degenerative change. Treatment, again, usually radiculopathies are treated non-surgically. Modalities for comfort initially. We talked about oral or epidural steroids if the pain is refractory. Again, the reasons for referral are progressive neurologic deficit, uncontrolled pain, myelopathy signs, bowel bladder changes. You know, again, we want to stay away from surgery. If it's done, usually ACDF, 1 to 2 level disease. With a 1 level disease, we'll talk about later, they are okay to go back to play. But again, we want to, most of these will do better non-operatively, and we want to, again, when we look at 1-year outcomes, it's very good for non-operative. So there's no reason to jump into surgery for these. Transient quadriplegia is something that they like to ask about as well. It's a fascinating entity, first described by Joe Torg. In essence, we talked about that neuropraxia leading to burners and stingers. This is a neuropraxia of the cervical cord. Again, bilateral, that's cord. Bilateral burning pain, tingling, loss of sensation in both arms or both arms and both legs. It can vary from mild weakness to complete paralysis. Prayerfully, it's transient. And again, this can be up to 2 hours. You can see the incidence there during Joe Torg's era of when this was examined a lot. It's thought to be either an axial load with hyperextension or hyperflexion, and it's thought to be a cord contusion via almost, you can think of the hip, FAI, the pincer mechanism, a pincer mechanism on the spinal cord causing that contusion. Again, we talked about that Csf Reserve. That is the most effective method of diagnosing this. We talk about the toric ratio, but there are flaws with the toric ratio because you may have a football player with big vertebral bodies, and they're going to come out with a toric ratio that is suggestive of cervical spinal stenosis. But really, functional reserve is the key. So it's the disc level spinal canal diameter minus the spinal cord diameter seen on T2 images, because T2 is our H2O, I always remember. T2 is water, so that's where we can see our fluid the best. And again, I don't think they can ask you for an exact number on what the reserve is, but you have to have adequate CSF reserve. Cervical fractures and dislocations, again, spinal cord injury increased while head injury decreased in the 60s and 70s. Were new helmets and all, they helped. So we kind of saw a shift in the injuries, and we see less now cervical spinal cord injuries since rule changes in football, like we talked about in hockey. The spearing is deadly, and that's the thing, is if we talked about how many of the high school and college athletes have degenerative changes in the cervical spine. We talked about that lordosis being protective. If we eliminate that lordosis and we actually load it, that's when we get a problem, and that's when that cervical spine can buckle. and cause, again, fracture and then cord involvement. So that's why spearing is not good. So, but it happens accidentally, and this was a game actually 2 seasons ago with the Bears, and this guy escaped it, but exact wrong position to be in, not through any fault of himself. It was just the nature of the play, how it followed. But that's what we want to present. We want to preserve that lordosis so it has a shock absorbing capability, so the spine doesn't blow. And this is Daryl Stingley. That's the injury that paralyzed him there. So Torg described a population with a constellation of findings. The ratio of less than 0.8, that's the vertebral canal to the vertebral body width. And again, we saw it's not always that sensitive, because you could have somebody with a big vertebral body, and that's going to be a low ratio, but they actually might be protected because they have adequate CSF reserve. But that Pavlov ratio, loss of normal cervical lordosis, and degenerative change, that's called spear-tapular spine. They may still test on this aspect. Those are risk factors for cervical spine injuries. And you know, that if you have this congenitally, if you do have an inadequate CSF reserve and degenerative change and loss of lordosis, that's a contraindication to play. This is an athlete, actually, these are taken 1 week prior to him being rendered quadriplegic following a tackle. A fascinating study that he had issues that they did this study before, but again, this is all ligamentous. This is not bony wise. So again, the benefits of the research, because of that research, they banned spear tackling in 1976, and you can see the decreased incidence of quadriplegia starting with that ban. So how research can make a difference. So field evaluation, and Jeremy may be talking about this as well, but you know, again, we want to carefully take them off the field. We need to protect the airway if they're unconscious while protecting the C-spine. Usually leave the helmet on. We'll talk about that. If they have that midline tenderness, limited range of motion, or any neurologic symptoms, they need to be immobilized and transported. So they need to be on the spine board. Usually, again, this is a little bit of an area of controversy, usually with the helmet and pads on. If you have a crack team that does this all the time, and you're going to maybe not a level 1 trauma center where they may not be as familiar with this, okay, maybe that's the case where you take the pads off and stabilize before you transport. But most of the time, if you're going to level 1 trauma who knows how to do this, if you can immobilize, and it's better to keep the pads on. But there may still be some controversy with that. This was, and again, there's been a just update to the task force on the pre-hospital care of the suspected spine injured athlete. When deemed necessary, protective equipment may be removed prior to transport. So again, it's not a statement saying you have to remove it, but if your team is adept at it and you may be going to a place that may not be as adept at it, that may be the indication to do it on site. So again, assume they have a spinal cord injury when you see the downed athlete. ABCs, remember them, activate the EMS, minimize movement, head and trunk as a unit. Remove face mask. Usually most of these will have little latches now. You can do them, or appropriate bolt cutters with your team. And again, helmet pad removal only if experienced. You got to practice this. I know Stan Herring told me every Sunday they used to practice spinal boarding, every Sunday, to make sure that team is moving in unison. Again, in acute injury, flexion extension x-rays are not the greatest, but CT scan, that was where we're going to show our sagittal plane translation. So again, greater than 3.5 millimeters or 20%, or rotation greater than 20 degrees. Those are indications of an unstable cervical spine. So how do they get back? Everybody wants to get these guys back. They need to, get them back as soon as possible. We really need to differentiate the minor from the serious. So stingers, really, when they're neurologically intact, full strength, painless range of motion, normal neuro exam, they can go back. But and we really don't have any evidence-based information on how many is too many in a year, but some consensus opinions favor holding for play if they have more than 3 within one year. I've had kids with big lanky necks and have had 3 in 1 game, but again, we really need to ensure that neurologic exam is normal there. Cervical strain, if, again, we got to take care of it if there's that focal tenderness, and we have to get the appropriate x-ray imaging to ensure there's not that translation or rotation. If flexion extensions are normal, we got to have painless neck range of motion and good cervicothoracic stabilization. Ligamentous instability, again, they could be bony intact, but ligamentous unstable if there's greater than 3.5 millimeters horizontal displacement, or 11 degrees, greater than 11 degrees of angulation. That's an absolute contraindication to return. The disc, we want them to have normal neurologic exam. If they have surgery in one level, they may return once the fusion is solid and they have painless range of motion. 2 levels is relative contraindication, and 3 levels is absolute contraindication to return to contact sport. So that may be a testable question. So 2 level relative, 3 level absolute. But 1 level, again, good cervicothoracic stability, they can go. Transient quadriplegia, again, really, you need to ensure the functional reserve, and again, really not, rather than the Pavlov ratio, the functional reserve is adequate. If they have developmental stenosis with 1 episode, relative, but I tell you, I think anybody with a functionally, if they have that narrow, if they do not have adequate functional reserve, they are at risk and they should not play. So there's gutsy individuals. I know Joe Torg, I called him about people sometimes, and he'd let them go back as long as they had complete resolution. And even with adequate CSF reserve, there must be something in these individuals that causes that cord to contuse even with adequate reserve. So I'd be very hesitant to send somebody back with this. Stan Herring and Mark Harris had a good paper. These are absolute contraindications for return to play after an episode of transient quadriplegia. And basically, if you have anything, any kind of finding, any cortispinal defect, any functional spinal stenosis, anything at all, don't do it. But even after an episode like that, even with all normal, whoa, I still think there's something in there that would be a risk factor. But again, for the test and all, these are the absolute contraindications. Atlantoaxial instability is a common question that they ask because it's present in Downs individuals. About 10 to 20% have some degree of atlantoaxial instability, with a minority of those symptomatic. If they're symptomatic, they need to have surgical evaluation and no sports. If they're asymptomatic, you want to restrict them from the high-risk activities. There's been a lot of controversy between screening x-rays for this population, as there's a very poor correlation between the x-rays and symptoms. But again, to know the atlanto-odontoid distance greater than 3 to 4 millimeters is considered atlantoaxial instability. So there's 3s are cropping up a lot with the instability. Just to know, they may ask you these or show you radiographs of these. The Jefferson fracture is a burst C1 fracture. This is the one that you can get when you dive headfirst into shallow water. Then the blessed thing about these is a lot of times they don't have a neurodeficit unless that fragment is displaced. If there's greater than 7 millimeters displacement, then that's considered unstable. But a lot of these can be treated with a hard collar or some degree of immobilization, as long as they don't have neurologic compromise. C2 is the Hangman's fracture. It's, again, if they ask you about mechanism, there's 2. It's usually hyperextension, then secondary flexion and distraction. And that rope, when it kicks in, that's why they call it the Hangman's fracture. So again, the type 1s, the less severe displaced, would be a rigid collar. Type 2 and type 3 will be usually surgical because they violate that 3-column, Denny's 3-column theory. If more than 2 columns are involved, that's an unstable spine. Odontoid fractures, they like to ask about these usually just to know type 1s. They usually do very well. Type 2s are the base of the dens, and then type 3 are low in the body. So type 2 and type 3, the base and the body usually require surgical stabilization. Type 1s do well non-operatively. Clay shoveler's fracture, it's interesting to see, but it usually doesn't cause any neurologic deficit. They're very stable, but it's a C7 spinous process fracture, so you may often have this pointed out as a clay shoveler's fracture. And again, the ones that you really don't worry about, they're healed compression fractures, healed end plate fractures, healed spinous process fracture, the clay shoveler's fracture. But anything else, if there's a depressed compression fracture, there's a posterior element fracture, if any of those other ones we talked about, those are relative contraindications. And certainly any acute fracture, vertebral body fracture that impinges on the cord, retropulsion, anything like that, those are absolute contraindications to return to play. And just to know, they love to ask about Klippel-Feil syndrome. That's a congenital fusion of any two of the 7 cervical vertebrae. Type 1 is a single fused segment. Type 2 is multiple segments, but they're non-adjacent, so maybe a little more mobility is present. Type 3 is multiple fused segments adjacent. So contact and collision restriction if type 2 or type 3 above C3. So if that creates a very rigid spine there that's not going to be able to absorb force, but they tend to ask about that too if they're symptomatic surgical evaluation. That was a whirlwind, but that was it. You guys have any questions? Sorry if I went a little bit over there.
We did have, thanks so much for that. That was great. We did have one question. Dr. Hamish Kerr had answered it, but real quick, I'll run it by you as well. So Christine asks that she's run into some changes where EMTs that are covering would not spine board every suspected C-spine injury and would use the collar as an alternative. Have you heard of this, and do you have any comments on it at all?
You know, the collar really isn't enough if we're worried. And again, you know, I think that's the thing. These aren't. You'll board a lot. You'll board 99% will be fine. You know, but it's the 1% that we board for, and a collar alone just isn't enough to provide. It's like a walking boot versus a rigid shoe. You know, it doesn't immobilize enough of the segments to really protect them. I think it's good practice really to talk with your EMS team in any event that you're covering and see where they're at and see. But you know, most I think will be totally on board with it as long as they know you and they know your rationale and your concern for the athlete. But you know, really a hard collar is just not going to do it. It's not enough.
Okay, thanks. That was the only question we had. So in the interest of time, I think we'll move on. So Dr. Laskowski, thanks so much. Everyone out there, go follow him on Twitter, Dr. Ed SportsMed. And he also has a great recent paper that came out this month on the virtual musculoskeletal exam in Mayo Clinic proceedings. So especially for fellows, as y'all are doing more telemedicine visits, is a great paper to reference as far as how to do an appropriate musculoskeletal physical exam over telemedicine. So with that said, Dr. Laskowski, thanks so much. And we will move on to Dr. Whitley, if he can share his screen now. Dr. Laskowski, if you can stop share.
Thank you so much, Robbie. Thanks all. Take care now.
Yep,
Let me know
thank
if any
you.
questions. Bye-bye.
Right. Okay, we can see Jeremy's. Okay, so so for everyone, second talk today on Sideline Emergencies from Dr. Jeremy Whitley, who's a colleague of mine and a former co-fellow of mine here at Emory. He's an assistant professor of emergency medicine and orthopedics at Emory. He is currently the team physician, or one of the team physicians, for the Atlanta Falcons and for Georgia Tech Athletics. He was just like Dr. Laskowski, undergraduate at Duke, and did all of his training at Emory from medical school through emergency medicine residency and sports medicine fellowship. So with that said, I will let Dr. Jeremy Whitley take over from here.
All right, good afternoon, everybody. Robbie, thanks for having me on to kind of share this information that I think, particularly at this time of year, is so valuable. In the interest of time, we'll try to move through things pretty quickly. I've outlined this as a series of cases in which we'll talk through the initial stabilization, evaluation, management of some of the more common sideline emergencies you'll see as you go out into covering sports throughout your fellowship year. Let's see. So again, our primary goal is just to review the evaluation, emergency stabilization, and diagnostic considerations for any sideline management for the most catastrophic injuries that are frequently encountered in athletes. So we have a high school football player, sustains a helmet-to-helmet hit, immediately complains of headache and blurred vision. No LOC, but he is amnestic to the event. And so we'll talk about closed head injuries with the understanding that the popular thing to focus on is concussions, but the more worrisome things tend to be intracranial bleeds. And so we'll kind of progress through how you evaluate that and some of the diagnostic considerations you make as well. So head injuries are the leading cause of traumatic death in sports. It's estimated that 300,000 sports-related brain injuries occur annually, with 250,000 occurring in high school football players. Concussions are the most likely, but you also have to consider these potentially life-threatening events. So your classic epidural hematoma here, subdural and subarachnoid hemorrhage here. Concussions are caused by direct or indirect transmitted forces, primarily due to rotation, but also due to acceleration, deceleration forces. You may have heard the term coup contra coup. It's kind of, this is one where you see the athlete kind of fall back, strike their head on the turf, and they kind of bounce back. It produces cellular damage and changes that can have long-standing impact. As most of you probably are well aware, concussion is a clinical diagnosis. There is no single diagnostic test. Imaging does not help you diagnose a concussion. The other thing to keep in mind is that sometimes these symptoms are delayed in onset, and so you'll have multiple categories: physical symptoms, mental, sleep, emotional, etc. And a big part of understanding concussions, particularly at the high school level, is giving anticipatory guidance to the families so that they know what to watch for. The thing that you'll want to know is obviously when to remove an athlete from the field of play and when to refer to an ER for a more emergent workup and evaluation. So if you see somebody and they're suspected of having a head injury, immediately remove them from the field of play. If they're conscious, do your ABCs, so airway, breathing, circulation, followed by C-spine evaluation, as Dr. Laskowski was talking about in his previous talk. Your Glasgow Coma scale will be an adjunct to your thorough neurological assessment, but in essence, it's a way that you can quickly and methodically assess what is this patient's or this athlete's level of neurological function, taking note of their eye movements, their speech, and their motor function. Any unconscious player should be assumed to have a C-spine injury and immediately stabilized, as we said, in a hard collar, but also on a spine board. The two big things to be mindful of are when they're referred to an ED. If there's any focal neurological deficit, or if they have any worsening clinical status, you need to send them in. The classic one where you hear tragically about athletes, particularly high school athletes that die, is with these epidural hematomas. They sustain an injury. They may have a brief loss of consciousness, get on the sideline, say, I feel well. They have this lucid interval where they're functioning, nothing seems to be wrong, and they compensate quickly. And in that moment, you kind of lost your window. You worry about brain and uncle herniation, and eventually they arrest from a respiratory standpoint. But to prevent that, if you send it to ER, you're basically doing that to get imaging of both their CT and classically their C-spine. And we use a set of diagnostic guidelines and criteria to help with that on the back end, your Canadian or your New Orleans SCT rules. As we talked about your Glasgow Coma scale, again, quick way to screen what their level of alertness is. Looking at eye, verbal, motor responses. I won't go through those in detail just for the sake of time. So Canadian head CT rule, it's important to recognize what your inclusion and exclusion criteria are. And so if somebody has a GCS less than 13, this doesn't apply and they need to be shipped anyway. But what you're looking for is high risk conditions that may require neurosurgical intervention, whether that's a burr hole, whether it's decompression. And so if they have a GCS score of less than 15 at 2 hours after the injury, suspected open or depressed skull fracture, any sign of a basilar skull fracture, so that may be hemotympanum when you look in the ear, battle sign behind the ear, raccoon eyes around the eyes, in which it's representative of intracranial bleed in saying a basal skull fracture. If they have multiple repeated episodes of vomiting, the age greater than 65 won't apply as much, but then these lower risk, but still relatively significant, amnesia, dangerous mechanism, etc. If any of these things are present, then you should get a head CT. The New Orleans SCT rules are a different set of guidelines, maybe not quite as relevant for your athletic population, but it's good to know how these decisions are made either way. So all symptomatic players should not allow to be to return. Once you're getting off the sideline, you're putting into computerized neuropsychological testing such as impact. But that said, the SCAT bias remains the standard of care in most settings, particularly acutely. Prevention revolves around screening, technique modification, and protective equipment. So we'll move to our second case. We've got an amateur road racer here in Atlanta. We do the Peachtree Road Race every 4th of July. It's incredibly hot. It's 95 degrees, 80% humidity. There's a show in front of Piedmont Hospital that every year there seems to be some sort of heat-induced event. And so this particular athlete, his calves cramp, he falls to the pavement. So we're talking about exertional heat illness. Incidence varies between sports, but it is directly related to workout intensity, temperature, and humidity. And one thing to kind of help guide you with this is you'll have those ultra endurance athletes, the recreational athletes that do these road races, and then your padded players who are doing field sports, so lacrosse, football. This is the time of year where you have to be very mindful of those. They're broadly broken down into 3 categories: heat stroke being the truly emergent condition, heat exhaustion, heat-related cramps. You may also see exercise-induced hyponatremia and things like that. We won't focus on that as much now because, again, the primary focus of this talk is to just be cognizant and aware of what could happen and act accordingly and swiftly. If left untreated, this is a particular source of morbidity and mortality. It's the 3rd most common cause of death in young athletes. So it's something we need to take very seriously. Here in Georgia, especially I grew up down here, it seemed like every year there was some sort of tragic scenario where an athlete died or had significant morbidity that could have been avoided. Your wet bulb globe temp will be of paramount importance. And the formulas here, we won't get into the specifics of it, but in essence, it is a way of taking in the air temperature as well as the humidity to help give guidance about should you continue with activity, what is the risk associated with it, and if the risk is too high, what should you do from a modification standpoint? There's a curve that wouldn't really fit on this slide, but this gives kind of a low-level view of what you're looking at. So green, yellow, red, black, black meaning extreme or hazardous, you may need to consider rescheduling or delaying the event until the conditions have improved. Signs and symptoms are relatively non-specific, so you need to maintain a high index of suspicion. People can feel nauseous, they can have cramping, they can just feel malaise or fatigue. Some of this stuff you may see just by virtue of them participating in the event, but you always have to be mindful of, are there any CNS manifestations? So gait instability, ataxia, altered mental status, confusion, etc. Your gold standard for temperature assessment is a rectal temp. Now, I say this with the understanding that you may not always have a rectal probe available. You may not always have a place where you can privately assess that. And so if there's any concern that this patient has CNS manifestations and they may be overheated to the point they're not sweating, then go ahead and send them to the ER so that they can be evaluated formally. The severity of multi-organ failure directly relates to the amount of time that athlete stays in the hyperthermic range. So again, you don't want to necessarily be fumbling around trying to find the equipment if you don't have it. If you don't, as an ER provider, someone that works in the hospital setting, we would much rather you err on the side of caution and send them in as opposed to delaying definitive care. That said, management equals immediate cooling. You want to transport the athlete to a cooler, shaded area. Ice water immersion therapy if you have it, so a cold tub. If you don't, water mixed with cooling fans that are evaporative cooling is really how humans cool themselves anyway. And when the temperature gets so hot that the athletes lose the ability to do that, we're basically recreating that for them. Ice water soaked towels or cold packs to the neck, axilla, groin. This will help decrease your core temperature faster than placing it elsewhere. You may read or hear about IV management and things like that. In essence, that you don't have to do that. That's when you're getting into a controlled environment where we may be cooling through bladder irrigation, things like that. But again, immediately, you just want to immerse them, cool them, and then take their temperature. The goal is to cool their core temp no more than 0.5 degrees Fahrenheit every minute with an initial target of 100 degrees Fahrenheit. So you'll be frequently reassessing them. This is not somebody that you evaluate, diagnose, and leave by themselves. You'll constantly be coming back to the reassessing, checking on them. The key to all of this is preparation and prevention. And so appropriately acclimatizing the athletes this summer we're seeing a lot of this, right? Guys and girls haven't been playing sports for a long period of time. They're trying to get back into it, trying to accelerate seasons. But you can't overstate how important it is to gradually acclimatize them from a temperature standpoint, making sure they're adequately hydrated. When we get to the point of the event itself, making sure that you have reasonable emergency action protocols in place. This one we produced here is what we've used for the Publix marathon and a half marathon here in Atlanta in the past. And it just shows you kind of how you'll progress through this algorithm, at what point you transfer. And so every event that you're covering should have something like this. And again, the rectal temp is the gold standard. And so if you have access to that, that's great. But if you don't, for whatever reason, don't delay definitive care by trying to kind of work around that. If there's a reasonably high suspicion of concern, you want to go ahead and send them. An ice hockey player skating towards an open goal, he violently checked into their wall by an opposing player, falls to the ice, and obviously playing clutching his left side. So it's something that we don't often talk about because we're not dealing with musculoskeletal care as much, but thoracoabdominal trauma is pretty prevalent. It's the most common in deceleration and contact sports. It represents just under 1.5% of chest injuries in sports. Rib fracture is the most common spontaneous pneumothoraces with strenuous exercise and weightlifting. That percentage increases when you start talking about abdominal injuries. 10% of all abdominal injuries are sports related. Liver, spleen, kidneys are the primary organs injured in blunt abdominal trauma. And so we'll go through how you monitor that, how you evaluate that, and definitively treat it. I liken taking care of these sorts of injuries to a car accident. And so for me, it immediately shifts to advanced trauma life support. And everything in that is driven by algorithms and being incredibly systematic and consistent every time you evaluate these patients. So you want to engage your primary survey, going through your ABCDs. We already talked about ABC, airway, breathing, circulation. D is disability, and so that covers your kind of Glasgow Coma scale, and E, exposure. You want to make sure that you remove the equipment, that you have eyes on potential injury sites, that you can feel, that you can touch, because it will clue what you do from a diagnostic workup standpoint. You want to identify immediate threats to life. So those in the thorax would include a tension pneumothorax, an open pneumothorax, flailed chest with pulmonary contusion, massive hemothorax, cardiac tamponade, etc. Now, you may not feel comfortable doing anything about these in the field, but having it on your radar, knowing how to stabilize these patients quickly and then shift into a trauma center with definitive care is incredibly important. Got this picture of the angiocath here. Tension pneumothorax is one of those that if you have this available and you know your anatomy, you can truly save somebody's life. You do a needle decompression, the second intercostal space of the midclavicular line, and just kind of perpendicular down. You leave that angiocath in there, you've now decreased that tension pathology, right? So here, the classic example, somebody sustained a left-sided injury, they've got this fractured rib, punctured the lung, they've got a huge pneumothorax that's creating tension physiology, shifting the mediastinum to the right with tracheal deviation. If they've got decreased breath sounds or absent breath sounds, hypotension, distended neck veins, that is an indication for this. Know that if you do this, you've got to send them, because we eventually will have to convert that to a standard chest tube. But again, if you have access to this and it's something that you just keep with you, a lot of times I keep it just as an omen against bad things happening, but you can actually save lives with that. For the abdomen, it's a little bit more streamlined. Essentially, you're just trying to recognize signs of intra-abdominal hemorrhage. And we'll go through that in just a second. Your FAST, if you have got access to portable ultrasound, can be a helpful adjunct as well. For your secondary survey, you want to consider the mechanism of injury. Was this a direct impact or deceleration? And visualize both the anterior and posterior aspects of the thoracic abdomen. Be mindful for signs of acute injury. So this is what we call Turner sign, and where you'll be emblematic of potential pancreatic injury, retroperitoneal injury. You'll see I'm blanking, but hematoma on the flank as well. This is not typical bruising, right? This is not, oh, I just got an abrasion from being tackled or hit or falling on the turf. This is symptomatic of something more severe and insidious going on beneath the surface. Palpate. So if their athlete has rebound or guarding, or their abdomen is tender beyond what you would be expected, or we'll also say pain out of proportion to exam, Those are things to be mindful of. If that abdomen is rigid, if they can't tolerate being moved from one table to another without having excruciating pain, these are all signs that there may be some intra-abdominal hemorrhage and that they need to be transferred to a higher level of care. So again, we've talked about potential life threats. In emergency medicine training, we learn that you really can only bleed out 5 different places. It's on the floor, in your head, in your chest, in your belly, and the one that often gets forgotten is in your pelvis. And so certain pelvic fractures, they can bleed in your pelvis, hold a lot of blood, and you may not show that clinically quickly. So again, just having this on your differential diagnosis as you work through your algorithm is key. Hemorrhagic shock is ultimately the thing that you're trying to prevent. It's not a trauma lecture per se, but just so that you understand that obviously the more blood you lose, the more symptomatic you'll become. But in athletes, they're so well conditioned that you can have a substantial amount of blood loss, particularly in your abdomen, your pelvis, without necessarily mounting a response, right? Their blood pressure may already be increased somewhat because they're in the midst of competition. They may already be tachycardic. Their cap refill will be fine and they'll be maybe a little anxious, but again, these are all things that you might not consider unusual in an athletic setting anyway. The point being that you have to reassess these patients frequently because they can be fine, compensating well, and then all of a sudden start to become sick quickly. And by that point, you're behind the 8 ball. A couple of clinical pearls with respect to intra-abdominal injuries. Rapid triage and assessment is key. You want to identify and correct these immediate threats to life. Your abdominal exam is not sensitive or specific, and for that reason, you need to constantly reassess. Go back and palpate on their abdomen, look to see if there's any developing bruising. And if you have a FAST and are trained in how to do that, that can be very helpful. You're essentially just looking for evidence of free fluid in the abdomen, which would not be there. And in the setting of trauma, the presumption is that it's blood. If you've got a positive FAST, that is definitely an indication of going to the hospital. If you got a positive FAST with abnormal vital signs, that's an indication for emergent surgery. Concomitant injuries are often present. So if you have a rib fracture, think about a splenic injury. If there's gross hematuria, think about a kidney injury, and that needs to be sent in as well to get CT imaging. And again, the take-home point here is any clinical decompensation warrants transfer. So lastly, and again, I try to get you guys to your respective duties. A couple of athletes here, these you may not recognize as commonly, but here, Hank Gathers is pretty well known. His story is pretty tragic. So we'll talk about sudden cardiac arrest. This is the one that you always want to know what to do. This is the one that can go south quickly, and you never want to be in a position where you don't have the resources, aren't prepared to handle it. This takes on particularly increased importance with COVID and the risk of myocarditis and heart-related complications on the back end. But the nice thing is that when you're evaluating this, your approach doesn't change. It's the overall leading cause of death in high school and college athletes. It's much more common in males than females. Pathophysiology is wide-ranging. So you have got structural heart disease, counts for a majority of cases, so things like HOCM or aortic aneurysms and people with Marfanoid symptoms, myocarditis, commotio cordis. But the final common pathway is always the same. That's ventricular fibrillation. And so from here on out, I want to shift to, yes, you could do a talk on prevention and screening and exertion protocols and return to play. But this is, what do you do when that happens? And so just like with everything else, remember your ABCs. Even if it seems unlikely, assume a cardiac etiology and work backwards. The American Heart Association describes 4 links in the chain of survival, and that's early recognition and activation of EMS, early CPR, early defibrillation, and rapid transit. What you'll see missing from this are all the things that we do on the back end in the hospital, epinephrine, different sorts of calcium, things like that we do when running a code. But the only 2 things that are proven to increase survival rates has been studied are early bystander CPR and early defibrillation. So making sure you have an emergency action plan in place, knowing where your defibrillator is, making sure that everybody that's involved in the care of these athletes is familiar with how to use it. A lot of times they make it pretty straightforward. If you're at a high school and you're covering multiple events and the training is covering multiple events, making sure that they can get to it easily is key. So your BLS algorithm here, just kind of simplify, activate the response, start CPR. We don't even really worry about the administering rescue breaths anymore. The biggest thing is just doing compressions the right way. So hard, fast, and deep. BLS will tell you to do the 30 compressions in 2 breaths. But again, if you can't even remember to do that, just do the CPR, 100 compressions a minute, compression depth of at least 2 inches, allow for a full chest recoil after each compression. Those are the things that really save lives. And then obviously getting the defibrillator and the pad on the patient quickly. A quick note on the prevention and preparedness. Ideally, we screen these athletes for fatal conditions, so family and personal history, physical exam findings, so if they have murmurs that change with positioning, HOCM, you look for certain EKG findings as well, dagger-like Q waves, inferior leads, S&T wave abnormalities, dysrhythmias. You can spend all day talking about sports cardiology and reading athletic echocardiograms, but just understanding this part of the process. Again, the most important thing is just having an emergency preparedness plan and being well equipped to use it. Everything that we do on the sideline is a multidisciplinary approach. It involves the athlete, the family, the coaches, their friends, the sports medicine physician, us, the athletic trainers, the support staff, governing bodies of school, athletic associations, and then sports cardiologists, right? And so this is, it takes a team effort to keep these athletes safe. So in summary, just be systematic in everything that you do, follow your algorithms, maintain a high degree of suspicion at all times, identify and correct the immediate threats to life. And again, this is coming from me, our doc. If you're at all concerned or doubting yourself, don't be afraid to transfer. We would much rather that you do that in advance of things getting worse than not sending them. Bottom line is if you plan to fail, if you fail to plan, you plan to fail. So Robbie, that's it. Try to keep us on time.
Yeah, thanks, Jeremy. That was perfect. So I didn't see any questions, but one thing I did want to ask is, as far as ultrasound on the sidelines and a fast exam, is that something that's reasonable to do in certain situations, or is it more of just an academic topic? Have you ever used it on the sidelines before?
So have I used it on the sideline? The answer is no. That's something I just don't have the access right now. But the question of would I? Yes, I would. Your abdominal exam is just so unreliable for a number of reasons, right? You're dealing with body habitus. Everybody responds to pain a little bit differently, but this is an objective tool that if you know how to use it the right way, you can screen, right? And you can repeat that throughout the course of the game or the situation to see, are they clinically worse? Are they safe to go? It is more reliable than your abdominal exam, period.
Yeah. And do you think that is, so for the fellows, do you think that is something that is fairly, like, how long would it take them to learn that to be able to reliably use it on the sidelines, do you think?
I'm a little biased. Right. Training at Grady, you do it in your sleep. But, I've worked with our fellows here over the last couple of years, and with anything with MSK or with ultrasound, you just have to get familiar with what you're looking at. Personally, I think it's easier than a lot of the MSK ultrasound that we do because, again, you're training your eyes to look for specific things, just free fluid. So hypoechoic fluid where it shouldn't be. And the hardest part with that is positioning of the probe. I think in a sports medicine population, that's actually a little easier, right? There may not be as much redundant fatty tissue. You're not having to move, pendulous structures out of the way. And so you actually get pretty good imaging. I think that a weekend, an hour or 2 sessions of prepping and then practicing, within a couple of weeks, you should feel pretty good about it.
Yeah. So that's good to know. I think as we more and more get access to ultrasound on the sidelines for the current fellows, I think being able to do a quick fast exam and learning that is something that is reasonable and useful. Okay, with that said, thanks so much, Jeremy. Y'all go follow him on Twitter as well, Jeremy Whitley, or at Jeremy Whitley MD. And please don't hesitate with any questions moving forward. These lectures will be uploaded to the AMSSM YouTube channel. So for friends that didn't get to catch it today, please pass that along to them to look out for this lecture on the YouTube channel. And then also the next installment of the Fellow Online Lecture Series is going to be September 2nd at 12 p.m. Eastern Time. It'll be on the athletic heart with Aaron Baggish, moderated by Heather Saffel. So with that said, thanks so much everyone for tuning in, and we will catch you next time.